So the next examination of central nervous system examination is higher mental function. Students, in higher mental function examination, the following are usually seen: the consciousness level, handedness, attention and orientation, language, memory, construction, calculation, insight and judgment, abstract thinking. So first is level of consciousness. To be brief, I want to make level of consciousness. There are only 3 levels. Okay, one is drowsy, stuporous and comatose. Drowsy is a condition where you can arouse the patient by verbal commands. Patient is stuporous means you can arouse the patient only by a painful stimulus, either by a deep knuckle pressure or pinching. Coma is a condition where you cannot arouse the patient by any deep stimulus. So, it's not arousable to either internal stimulus or external stimulus. Then handedness, because the right-handed person, the dominant lobe is left lobe in 90%. The left-handed person also 60 to 70%, left lobe is only dominant. So, next is attention and orientation. Attention and orientation is tested by mini mental status examination. So, let us see how the mini mental status examination is done with the diagram. Hello, namaste students. So, central nervous system examination will start with general physical examination and higher mental functions. So, I told you about what are the things you should look in general physical examination. Okay. Now, let us go to the higher mental function examination. In the higher mental function examination, okay, so we have discussed what are the things to see in the consciousness, level of consciousness, then handedness, then next is the orientation and concentration. For the orientation and concentration, you will do mini mental status examination. Okay. So, what are the things you ask in mini mental status examination? Okay. So, these are the questions which you will ask in mini mental status examination. Okay. First is orientation. Okay. In the orientation, you will ask what are the day, date, month, season and year. So, each one will get 1 point, that is 5 points. Then, where are we? Okay. Country, state, city, hospital, floor. Each will get 1 point each, so that is 5 points. This is orientation. Next is registration. For registration to test, you name 3 objects, 1 second to say each, then ask the patient to repeat all the 3 objects. Give 1 point to each correct answer. Then repeat some 3-4 times until all the 3 objects are registered in the patient's brain. So that is 3 points. Next is attention and calculation. You can tell the serials of 5, 7, 14, 21, 28, 35 like that. Give 1 point to each correct answer. Stop after 5 answers. Alternatively, you can ask the patient to spell the words backwards. So that is 5 points. Then recall. Whatever is in the third, the registration, you are given the 3 objects. You tell the patient to repeat those 3 objects. So, give 1 point to each correct answer. That is 3 points. Next is language. In language, you name a pencil and a watch. Okay. So, if he names a pencil and a watch, it is 2 points. Then, repeat one following sentence depending upon his language, whichever he speaks. If it is English, no, it's, and, or, buts. So, that is 1 point. Then, follow a 3-stage comment. For example, take a piece of paper in your right hand, fold it into half and put it on the floor. So, it is 3 points. Then one more 3-stage command you can give, something like similar to the first 3-stage command. Then read and obey the following. For example, close your eyes, lift your hand, he has to read and he has to obey it. For this, 1 point. For a 3-stage command, 3 points. Then he has to write a sentence, one point. Then copy a design, a triangle or a square or a rectangle. So this language will have 9 points. So the total points in mini mental status examination is 30. Depending upon the education level, it varies from 24 to 27, the normal score. In our patient, we had applied this and he scored around 27, mini mental status examination. This mini mental status examination is a little laborious process. So there is one simple examination, short orientation memory concentration test for cognitive impairment. So here we will use simple questions like ask the patient to name the month, name the year, state the time of the day. Remember the following memory phrase: John Brown, 42 Market Street, Chicago. Then count backwards from 20 to 1. Name the months of the year in a reverse. Then recall that memory phrase in the 4 whatever you are told. There is one more mental status questionnaire is MSQ, that is out of 10, if more than 8 it is normal. These are some of the methods to assess the orientation and concentration. Okay. So I have done the mini mental status examination on this patient. His score is 27. 24 to 27 is normal range. Okay, and there are even short forms of mini mental status examination which I told you, short memory test and mental status questionnaires. The next higher mental function is language. Language, there are 3 things: phonation, articulation and language. Phonation is a problem with larynx. Articulation is a function of brainstem cranial nucleus. Articulation involves the 5th nerve, 7th nerve, 12th nerve, 9th and 10th nerve. 5th nerve, 7th nerve, 9th, 10th and 12th nerve. Hello students, just I want to add one point in the discussion of the higher mental function in the language examination. There are different types of speech sounds. For example, you will use your lips for labials, papa, baba, ma, that is labials. Then you will use your tongue for some of the sounds for ta, ta, da, da, na, that is linguals. And gutturals, kaka, ga, ga, na, gutturals. There is one word which will use all the 3 things: labials, linguals and gutturals. Pataka, pa is labial, ta is lingual, ka is guttural. Okay students. Then language. What is language? It is the ideas and the thoughts which can be expressed by speech and writing. That is a language. And the disorder of language will be in the cortex. So phonation is larynx, articulation is brainstem, language is cortex. Usually neurological problems will have problem with the articulation and language. There are different types of dysarthrias with the problem with the articulation: flaccid dysarthria, spastic dysarthria, rigid dysarthria, mixed hypokinetic and hyperkinetic dysarthrias. Flaccid dysarthria you get in a bulbar palsy. Patient will speak as though some mashed potato is there inside his mouth. Usually phonation and articulation both will be affected, and in the end stage it leads to anarthria. In a spastic dysarthria, there will be explosive quality to the voice. For example, a British constitution will speak as British constitution. There will be exaggerated jaw reflex. Rarely it leads to anarthria. Motor neuron disease produces both flaccid and bulbar palsy as well as pseudobulbar palsy. That is rigid dysarthria. The spastic dysarthria. The rigid dysarthria you get in a Parkinson disease where the patient will speak in a monotonous low pitch voice, also known as hypophonia. Now come to the disorder of language. Disorder of language, okay, you have two main aphasias, Wernicke's aphasia, Broca's aphasia. The other aphasias are global, conduction, transcortical motor, transcortical sensory and mixed transcortical. The Broca's area is situated in area number 44. It is also known as expressive aphasia, non-fluent aphasia, motor aphasia. Here, he will use only little small words. That is why it is known as a telegraphic speech. And comprehension is normal. That means whatever you say, he obeys. Comprehension is obeying to the commands. So, comprehension is normal. Prosody will be lost. What do you understand by prosody? Prosody is, for example, if you become angry, you speak in a different pitch. If you are sorrow, you speak in a different pitch. That he won't do. In a single same pitch he will speak. The prosody will be lost in a Broca's aphasia. Next is Wernicke's aphasia. It is area number 22. The Broca's area is situated in the inferior part of the frontal lobe. The Wernicke's area is situated in the superior part of the temporal lobe with the junction with the parietal lobe. It is area number 22, Wernicke's aphasia. It is also known as sensory aphasia, receptive aphasia, fluent aphasia. Here, you will keep on speaking, fluency is normal, but comprehension is abnormal. He won't obey to your commands. He will use the word which is not given in any dictionary, that is called as neologisms. And jargon speech, he will speak in jargon. There are paraphasias in Wernicke's aphasia. Paraphasias are different types. There is one literal paraphasia and verbal paraphasia. Now, little paraphasias, you will substitute a single letter. For example, for cat, you will say mat, rat, jat, something like that. The verbal paraphasias, totally different words he will use. For a mat, he will say pencil or a ball, something like that. Usually, clinical scenarios, Wernicke's aphasia is rare. We get only Broca's aphasias. Global aphasia is a problem with both Wernicke's and Broca's aphasia. Everything will be problem, fluency, comprehension. In a conduction aphasia, everything is normal, comprehension is normal, fluency is normal, but the only problem is repetition in a conduction aphasia. For example, for elephant, if you say ELEPHANT, you won't be able to repeat it, elephant. That is conduction aphasia. Then transcortical motor, transcortical sensory and mixed transcortical. In a transcortical motor, the connection of the motor area to the surrounding area will be cut off. It behaves like a motor aphasia, that is Broca's aphasia, but repetition will be normal. So, in a conduction aphasia, repetition will be abnormal. In a transcortical motor, repetition will be normal. In a transcortical sensory, it behaves like a sensory aphasia except repetition will be normal. Whereas in a transcortical mixed, the only thing which is normal is repetition. So, this is about disorder of language. I will discuss the major aphasic syndromes. Okay, now I just put it in a table and I want to summarize it for you people, the major aphasic syndromes. Okay, see here the Broca's aphasia. The Broca's aphasia, here comprehension is normal. See here, comprehension is normal, but fluency is abnormal. And rest all repetition, naming, reading, writing will be abnormal. Only comprehension is normal in Broca's aphasia. In Wernicke's aphasia, fluency is normal, comprehension is abnormal, and rest repetition, naming, reading, writing will be abnormal. Whereas in global, everything will be abnormal. Fluency, comprehension, repetition, naming, reading and writing. Okay? In a conduction aphasia, everything is normal, only abnormality is repetition. Repetition will be a problem. That means if you ask the patient ELEPHANT elephant, he won't be able to repeat the spellings ELEPHANT elephant. So, that is a conduction aphasia. Okay, repetition will be abnormal. Then there is something called as transcortical motor, sensory and mixed. What happens here is Broca's area will be cut off from the surrounding areas and Wernicke's area will be cut off from the surrounding areas. So here transcortical motor behaves like a Broca's except that the repetition will be normal. Okay, repetition will be normal. Transcortical sensory behaves like a Wernicke's aphasia except that the repetition will be normal. See, fluency will be there in sensory. Fluency will in transcortical motor, comprehension will be normal, but repetition also will be normal. In transcortical sensory, repetition also will be normal. Behaves like a Wernicke's except that the repetition is normal. Then there is a transcortical mixed where both fluency and comprehension will be abnormal, only repetition will be a normal. Okay, these are some of the major aphasic syndromes. In a transcortical aphasias, repetition will be normal, remember like that. Otherwise, they behave like their motor and sensory counterparts. Okay, right. This is a major aphasic syndrome. Now, next come to the memory. Memory has four things: reception, registration, retention, recall. Reception, registration, retention and recall. It has immediate memory, recent memory and remote memory. Immediate memory is within seconds. You give a digit span, for example. That is the immediate memory. You have to tell it within seconds, minutes. Recent memory is within hours and days. Usually in a Alzheimer's disease and dementias, recent memory will be lost. Whereas immediate memory is lost in acute confusional states and Korsakoff psychosis. Remote memory, you can ask his date of birth, president of that country, his marriage anniversary, like those kind of things. That is about memory. So next is construction. You can give some diagrams to the patient, ask him to write it, or else you can make some figures with the matchbox, tell him to make the same thing. For example, so you give some figures, some structures to him with the matchbox, he should be able to do it. For example, a triangle I have given. Yes, he did it. He did it. That's right. So I'll give some construction figures to him and he should be able to do it with the matchbox. Okay. Right. So I have constructed here a square. Let us see. I'll give to him to do it. So he did it. Next I'll give one more construction work. So I given this shape this time. So let us see whether he will do it. Curry. So he has done it. Okay, right. So students, this construction apraxia, which we will discuss in apraxia, you get in a non-dominant lobe disorders. Okay. So next is calculation. Calculation, you tell 100 minus 7, tell him to keep on minus till around 5 times. Okay. Or you can tell a number to double it. That is calculation. Acalculia you get in one of the syndrome, Gerstmann syndrome. Okay. Gerstmann syndrome, right to left confusion, acalculia, agraphia and finger agnosia. It is a problem with a dominant angular gyrus. Okay, angular gyrus. Right to left confusion, acalculia, agraphia, then finger agnosia. That is calculation. Okay. So next is insight and judgment. Insight and judgment. You will ask the patient whether he has a proper judgment by putting some question. For example, if suddenly some fire comes in a theatre, what he will do? Or in the lift, if suddenly power cuts off, what he will do? Or if a banana peel is there on the road, what he will do? So this is an insight and judgment. These sort of questions you will ask him. Next is abstract thinking. Okay, abstract thinking, you will give the patient some scenarios and you will ask him to tell the differences or similarities. For example, you will ask the patient, what is the difference between a stone, wood, a chair and a water? Or you will ask the patient, what is the similarity between a scooter, a car or a bus? Or what is the difference between a scooter, a bus, a car and a boat? Or what is the difference between a lie and a mistake? Like these sort of questions, similarities or differences you will ask. for abstract thinking. Okay, right. Now, the next important thing of the cortex is agnosias and apraxias. What is agnosia? Agnosia is difficult to interpret the meaning of a stimulus even though it is perceived. They'll perceive the stimulus, but they're unable to recognize the meaning of that stimulus. What are the different agnosias? Tactile agnosia, you touch, they feel the touch, but they couldn't make out it is fine touch or pain or whatever it is. Tactile agnosia. Olfactory agnosia, they'll smell it, but they couldn't say what is the smell. Visual agnosia, they'll see it, but couldn't interpret the meaning of that stimulus. In the visual agnosia, there are two types, simultaneous agnosia and prosopagnosia. Prosopagnosia is inability to recognize the face. Simultagnosia is multiple impulses they cannot make out. For example, if you take them to a forest, they'll say only trees are there. That it is not a forest because only trees they can see. Simultaneous impulse they cannot interpret. Simultagnosia. Autoposognosia, their own body relation they cannot understand. One of the type of autoposognosia is finger agnosia. This index finger, middle finger they cannot make out. Stereognosis, inability to recognize the object texture by feeling the touch of that objects. Inability to recognize the objects. Stereognosis, astereognosis. Anasognosia. What is anasognosia? The paralyzed limb he cannot recognize. That is a feature of non-dominant lobe, anasognosia. So, tactile, olfactory, auditory, autoposognosia, anasognosia, astereognosis, simultagnosia, prosopagnosias. These are the different agnosias. Even visuospatial agnosias. Next is apraxias. What is apraxias? Apraxias is difficulty carrying out the skilled motor activities even though there is no motor weakness, sensory weakness or ataxia. These are apraxias. There are different apraxias. Gait apraxia, they cannot be able to walk even though there is no weakness. Eyelid apraxia, if you ask the patient to close the eyes, they won't be able to do that, or open the eyes, they won't be able to do that. Eyelid apraxia. Gaze apraxia, you look from one gaze to the other gaze, lateral or medial gaze, they won't be able to do that. Gaze apraxia. Buccophageal apraxia, whistle, put the tongue out, they won't be able to do that. Buccophageal apraxias. Constructional apraxia, now I told the patient to do square and triangle, they won't be able to do that. Constructional apraxia is a feature of non-dominant lobe and also seen in hepatic encephalopathy. Dressing apraxia, they won't be able to don the dress, dressing apraxias. Visuospatial apraxias. Then sympathetic apraxia. Sympathetic apraxia is if there is a weakness on one side of the body, the other side which is not having the weakness, from that side also they cannot do the motor skilled activities. For example, to salute or to say goodbye. That is sympathetic apraxias. Next is ideomotor and ideational apraxias. Ideomotor is inability to carry the complex activities on command. For example, to salute, to say goodbye. Then ideational apraxia. What is ideational apraxia? Individual components they can do it, but not as a total act. For example, for this patient now, if I ask him to light a matchstick, he won't be able to do that. But instead, if I ask him to open, take the matchbox, give a friction, then he will do the individual parts. That is ideational apraxias. So this is about apraxias. Next is disconnection syndrome. One of the important disconnection syndrome in CNS is alien hand disorder. In an alien hand disorder, okay, there is a goal-oriented involuntary movement of the one side of the body, one hand. My friend had this alien hand syndrome. He was driving, but the other hand used to put the brakes or the gears, which used to produce a lot of problem to him. So that is alien hand syndrome and disconnection syndrome. So student, this is about higher mental function examination.